This episode is sponsored by Grow Therapy. Grow Therapy was founded on the belief that quality mental health care should be accessible. It makes finding an in-network therapist easy. Go to growtherapy.com to find your match and let insurance pay for your therapy.
Welcome to a place where you'll leave feeling whole. The Counseling Podcast brings at-home counseling right to you, focusing on self-care, self-expression, and breaking down barriers. Dr. Jacqueline and Dr. Stokes bring over 20 years of combined experience and a new sense of style to the word counseling. The two use humor and lighthearted conversation to explore these deeper feelings. Let's take the stigma away from counseling together.
Welcome to the Counseling Podcast. We have a special guest today, Kendra Wilson. Hi, how are you?
Hi, good. How are you doing?
Good. Why don't you go ahead and introduce yourself?
Sure. My name's Kendra Wilson. I'm a licensed clinical social worker in Virginia and North Carolina. I'm also a certified eating disorder specialist supervisor with the International Association of Eating Disorder Professionals, a certified DBT counselor, and a certified trauma professional. I've been working with eating disorders and trauma and all of the things that go along with that since 2004. And right now I'm getting away from the administrative director side of things, and I'm doing outpatient virtual private practice.
Great. So who do you work with specifically?
I work with adults with eating disorders, over 16 actually, but a lot of those fall into one of two demographics, either college students or sort of mid-30s to mid-40s women who have probably had their eating disorder for quite a long time and just now are realizing the extent of the problem and are getting help. Sometimes that's just the stage of life that they're in, and sometimes it's because they see eating disorder behavior in their kids that they don't want to see, and they don't want to continue that cycle. And with the college students, they are the more typical eating disorder population. So people are generally more on the outlook for eating disorder symptoms and behaviors in teens and young adults, especially women, though the incidence of eating disorder in men is rising. But the highest increase in age group of when people are diagnosed with an eating disorder is women 45 to 60. So that's becoming more and more prevalent.
And I was actually going to ask, when people, I think of eating disorders, they think automatically women.
Mm-hmm.
Do you have a lot of men that come see you?
I have a fair number of men, and in the area that I'm in, a lot of them are military. So it's kind of an interesting dynamic to see because there is a lot of eating disorder related issues in the military with the way that they have them qualify for service and the physical training aspect of it, and also the nutrition aspect of it when they're deployed is not a great situation. There was a article I think in November from one of the military magazines that highlighted so many issues, some that I didn't even know about, that happen in all branches of the military. So I have a fair number of military clients in general, but interestingly, most of the men that I see are either in the military or have had their eating disorder for a while, and someone has realized how significant a problem it is and has encouraged them to get help. They are rarely the college student population that I see.
So curious for our listeners, I know that there's a lot of, misconceptions about what an eating disorder is and what that might look like. So for our listeners, if we have anyone who maybe thinks they might be struggling with any kind of disordered eating or any issue related to food, what are some things for folks to look out for and be aware of?
So the first thing is the thing that everybody notices, and that's anorexia. Those restricting symptoms, if people are not eating in front of other people, if they are, let's say they bring their own food to Thanksgiving, they don't engage in social interactions because almost all of our social interactions are around food, or weight loss is a typical one that you might see, but also other physical symptoms that you might notice are just fatigue and weakness, fainting. Sometimes people get sort of a grayish cast to their skin, and all of those are signs of malnourishment. The thing is, malnourishment can happen no matter what weight you are. So it's a thing that we often miss in people who aren't lower weight. There are a ton of people who restrict their food intake in various ways, but don't fall into that typical paradigm. So if you see someone who to you looks overweight and they're bringing their own food to Thanksgiving, people might be supportive of that and like encouraging and tell them it's a good thing, when they might be in just as much trouble medically as someone who's underweight. And also, the younger you are, the more likely you are to bounce back from that stuff. So that also gets more difficult as you get older. The other things to look out for are another category is over-exercising. And people might not necessarily, again, consider that a negative in most situations. But when people exercise, like even when they're injured against doctor's advice, or when they get upset and agitated when they can't exercise, or when they go to extreme lengths to do it, like maybe if they're on a trip and they go run at night in an area that they're not familiar with, or maybe just run at night in general. Like those are the kinds of riskier behaviors that would indicate that this person might have a problem with exercise, over-exercise. And then the other two categories are a little bit harder to identify. Purging behaviors are really secretive and shameful. So it's really unlikely that you would notice those behaviors unless perhaps you live with someone. And I would say those are the most dangerous set of behaviors. So if you notice anything that makes you think that that person is throwing up or using laxatives or doing any other like extreme behaviors, especially if they disappear after eating a meal for a little while, or take like, I know teenagers take really long showers, but like ridiculously long showers where you're worried about what's going on, or they faint when they get out of the shower, like those kinds of things you might notice. And they're the most dangerous set of behaviors because it can increase your cardiac involvement and it lowers your seizure threshold when you're dehydrated. So that's where the main problem comes. It's when all of those things are present together, it's the most dangerous version of an eating disorder. And that actually doesn't matter what weight you are. If you have restricting and malnourishment, if you're over-exercising, and if you're purging in some way, like that's the trifecta that you really want to be concerned about. The last category is binging. And again, it's very secretive and shameful, but you're much less likely to notice negative consequences, like physically. You might notice weight gain or something like that, but most of the time, you won't have any idea that the person is binging unless they tell you. And people of all weights and sizes do engage in binge eating disorder. It's the most common eating disorder. And it's pretty high percentage when it comes to like mental health illnesses. It's like 3.5% of the population, which is like ridiculously high. So it's the one that is the most misunderstood and the most recently added to the DSM. It's only been a diagnosis since 2015, technically.
And like you said, there's that secrecy part of it. So do you have a lot of people that come that brought themselves there? They're like, hey, I want to talk about this and I want to fix this. Or does it clients that like their, family members are like, we're concerned about their behaviors?
So it usually is sort of a combination of the two. Usually it becomes unbearable and the person shares what's going on with some member of their support system who then encourage them to get counseling or seek a qualified provider. And one of the biggest problems there is Diet culture and weight stigma are a big problem in healthcare. So if you send them to if you just send them to their primary care doctor, or you send them to a general therapist, that person might not ask the questions that they need to ask, because most of us are afraid to ask those questions. Most of us don't want to talk about weight and food and all of the behaviors that go with that, because it's such a touchy subject in our culture. And so they're much less likely to actually get help if they don't go to a specialist.
And before the podcast, you were talking about a lot of different providers that someone would have to see. Can you kind of touch on that a little bit?
Sure. Ideally, if someone has an eating disorder, they would see a therapist and a dietitian at minimum. And both of those people would be specialists and qualified to work with eating disorders. There is a separate certification through IDEP, the International Association of Eating Disorder Professionals, for registered dietitians. And that's important because not a lot of registered dietitians are trained in working with eating disorders. So if you go to someone who just works at a hospital or a general outpatient practice, they're going to be much more focused on like cardiac issues, diabetes, weight loss. They might not see the signs either. And then also, ideally, you would have a doctor involved. That person could be a medication management provider, primary care doctor, gynecologist, or some other kind of specialist, depending on what's going on with you. But someone has to see the client in person at regular intervals. Since I'm a virtual only therapist, that someone has to be the dietitian or the doctor. And usually it's not the family therapist, which is also highly recommended, if not required, if you're an adolescent, to have that as well.
I think it's great that you're pointing out the necessity for this really comprehensive approach. I think one of the things that makes eating disorders, one of those mental conditions or psychiatric conditions that can have a really strong physical health component. It makes sense that you want to involve these other human service professionals to be able to keep track of what's going on, particularly, in cases, as you mentioned, like anorexia, where, a person's health can really obviously be on the line. But then also, I think it's important that you mentioned the family component, particularly if it's an adolescent or a young adult, as a way to kind of keep an eye on what's going on from a familial standpoint. And I know that with eating disorders, there is a strong family component oftentimes, from what I know, particularly with anorexia and bulimia. Do you want to talk a little bit about that?
So the family component is an interesting one because it's partly genetic and partly behavioral, as most things are. There's certain genome factors that make you more susceptible to one of those biologically based mental illnesses, and anorexia and bulimia are both considered those. They actually make us more susceptible to all of them, not just to one or the other. So if you have a family history of general anxiety, OCD, bipolar disorder, major depression, anorexia, bulimia, or panic disorder, like I think that's 8 of the 10, then you are more likely to have a child that has one of those things as well. And it seems to me that personality is one of the biggest factors in whether or not that develops into anxiety, depression, or an eating disorder. And that's so many factors that I couldn't even try to fathom. But one thing that you will notice is there's certain personalities that are associated with the different diagnoses. So anorexia is more associated with kids that are very anxious or perfectionist, very high achieving. They have a certain need for control. Kids diagnosed with bulimia tend to have a little bit more of that impulsive side, but they often have that impulsivity on top of the perfectionist and controlling tendencies. So that can get pretty confusing. And then they really haven't done enough research on binge eating disorder development to say a personality type in particular. But something that you said when you started to ask the question, is anorexia being the most medically involved? That's one of the misconceptions that I think is really important to address. It's the malnutrition that's the problem, not the weight. So Dr. Jennifer Gaudiani, who used to work at Acute in Denver, wrote a book called Sick Enough. And it's all about how eating disorder clients have this thing where they think that they need to be a certain degree of sick in order to qualify for treatment, that they have to weigh a certain amount or they have to have a certain number of behaviors. And that's the part that's really dangerous, because it doesn't matter if you're hundreds or even dozens of pounds overweight, you can still be malnourished and still have all of those complications. It's just that we don't really think about it. We even endorse those behaviors in people who are severely overweight. And that gets really damaging to the overall idea of it, because you have no idea by looking at someone what they might be doing to their bodies in a variety of ways, but with eating disorders especially, it becomes really scary, the damage you can do. And if you're under 25, you can recoup a lot of the bone loss and even the damage to your brain. The white matter of your brain deteriorates if you're malnourished, so you can't think as clearly, you can't make those connections. And you can get a lot of that back. But if you're over 25, you can't really get the bone loss back. And so you're stuck with the osteopenia or osteoporosis. And that happens after only 3 months of malnutrition, not of being underweight, but of malnutrition. That's the part I think is really important to focus on.
That's definitely scary. What kind of modality do you use, and what is, if someone's coming into your office, what can they expect in the treatment plan?
So I've been a DBT specialist for a long time, so that is my starting point with most clients. But I like to take a little bit of an eclectic approach, because DBT is the basis, but depending on the client, a lot of times I will use RODBT and compassion-focused therapy. And when I'm working with someone who has trauma, I'll use cognitive processing therapy as well. And so it all kind of mixes together. I also really like the values sort exercise with ACT. I think almost everybody do that at some point or another, because you get away from your values when you're stuck in your illness, whether that's an eating disorder or depression or anxiety. You really don't have those things and live consistently within your values with integrity at the same time. So it's important that you even know what they are. Most people don't even know what their core values are.
Yeah, and I think that something like going through an eating disorder, I'm sure that because of all the behavioral and emotional manifestations of that, things like values, and something that is probably really important for a person to become intimately aware of as they're beginning their treatment and recovery process.
Absolutely. Values are hugely important, and we don't think about them enough. We don't identify what our values are or put them in a ranking to just like when we're making decisions and all of the things that exercise makes you do. And also, like, people usually feel a lot of shame and guilt about their eating disorder behaviors, even when they're getting reinforcement from outside sources that is encouraging their eating disorder behaviors or reinforcing them in some way. So knowing what your values are and what the eating disorder's values are can be helpful in making a distinction between what you were really going for and what your illness is making you go for.
And it sounds like you help them to create a separation from them and their illness, right? This idea of like,
absolutely,
you are not your illness sort of thing.
Yeah, a lot of times people will call it Ed or Edna or Anna, and there's a lot of pro-Anna websites and social media aspects out there. So if you ever hear that term, that's what that means. It's pro-anorexia or pro-eating disorder. And so Obviously, if you fill your Instagram feed with that, you are going to get a lot more reinforcement for eating disorder behaviors than if you go in the more body positivity, weight neutral side of things.
Can you talk a little bit about, so it's interesting that you should bring that up. I work with a lot of teenage clients, adolescents, and I had an adolescent actually share with me recently that that's a thing, that there are anything is a thing now. I've learned that in my life the last couple of years. When it comes to the internet, I'm pretty sure you can find just about anything, but talk a little bit about this whole movement of pro anorexia. Talk a little bit about that.
Well, it's actually been around probably for a lot longer than you realize, because we've been talking about it and dealing with it. I think the first time I remember having a conversation in family therapy about it was in like 2005. So it was before Facebook, before Instagram, before any of that stuff had become part of our daily lives. And it was just the internet had stuff like chat rooms and things, if you can remember that far back. But now you can find it anywhere, just like you can find the other side of it anywhere. The pro-ana stuff is pretty easy to recognize because it's just so ill. It's like the pro self-harm stuff that's out there in the worldwide everything. You can find something to reinforce any point of view. So one of the things that I do, especially with my younger clients, is try to engage them in critical thinking, get away from that confirmation bias of everything you see just reinforcing your worldview, and think about what that really means or does long term sometimes. As people do more like health at every size and talk more about weight stigma and talk more about body positivity, inevitably you're going to get backlash for that as well. People are going to entrench themselves in that pro-thin, pro-anorexia, pro-dieting worldview. It's just the question is, who is it serving? Because that's the big problem. It's making money. So they're not going to shut it down. There's worldwide like hundreds of billions of dollars wrapped up in the dieting industry every year. I think it's like 240 billion. So everyone is invested in that, not on the other side of it when it comes to advertisements. Things you don't even realize are really reinforcing that attitude. Like I've often had clients come to me and I will ask to see their Instagram feed and look at what they're exposing themselves to every day. And they don't even necessarily recognize those things as disordered. It can be Fitspiration or Finspo kind of stuff. It can be chauvinist or misogynistic stuff. It can be all kinds of prejudice, and you don't even notice it sometimes.
And with those adolescents and young adults, they're constantly comparing themselves on Instagram or Facebook. And so, even with body positivity, they're going to find something wrong with their body if they're constantly comparing.
And the constant comparison is having a pretty significant effect on adolescent mental health. We can't prove causation between social media and the deterioration of adolescents in terms of mental health, but we can track the increase in hospitalizations and the increased need for mental health care. Like between 2011 and 2019, one statistic that I saw that was from a pretty reliable source, I think it was in JAMA, was that it increased 170%. Hospitalizations for suicidal behavior among adolescent girls increased by 170%. That's a ridiculous number. What did we do between 2011 and 2019 that was different than the years before? One of the things that we did differently was social media. And that we can't say that that's the only factor, but
Yeah.
the way people respond to it, it's got to be a factor.
When I think everything is glorified now, anything can be glorified, you know? I mean, even if we look at and not to liken eating disorders to addictions, chemical addictions, but we know there's some overlapping symptomology and things like that, but addiction can be glorified as well, and substance abuse can be glorified as well. So I think anything that has a platform to become glorified is, and I think that's what our youth is, a challenge that our youth has today that it didn't years ago.
Yeah, like cigarettes used to be glorified in the 50s and 60s in the media, and now hopefully everyone on the planet has heard that they're bad for you. So you can't get away from that pre-contemplation stage if you're smoking. But now it's vaping and eating and self-harm and various other risky things. It's always going to be something. I don't know if we're ever going to eradicate all of the ways that we can harm ourselves.
And that's why education and mental health care is key. Which leads me to my next question. You know, what is and obviously working with people on an individual and group basis, you know, as therapists, we do our best to impact the people who are in our proximity. But, you know, on a mass level, what do you want our culture, what would be a good thing that you would want our culture to learn or to adopt in terms of its, you know, people's relationship with eating, people's relationship with food?
I would say two things. One, I would like our culture to adopt in general a willingness to talk to each other and ask questions without judgment, like a certain amount of open-mindedness and willingness to share and be vulnerable would be awesome in a variety of ways. But it does especially apply to food because people are incredibly uncomfortable talking about food and body image. It's almost worse than talking about money. Like, it makes people cringe if you ask them how they feel about their body. It's so hard to get away. You can't get away from your body. Everyone has it. Everyone has feelings about it. And how often do we actually talk about it? So that's one thing that I would just like in general. But as far as eating disorder specific stuff, I would really like people to stop making it black and white. Good and bad, good and evil, healthy and unhealthy. The word healthy has turned into a slur practically among clients. If you call someone healthy in an eating disorder treatment center, they hear you say fat. Never want to call them healthy. And never say anything remotely along the lines of, oh, just go eat a cheeseburger. Because that is so unhelpful, and it's really not about the food. Food is a coping mechanism, and in that way it is like addiction. But sometimes I tell people that having an eating disorder is like someone who is an alcoholic in recovery having to sit in a bar with their favorite drink in front of them 6 times a day and not drink it, while holding it to their face. Like doing that 6 times a day, every day. So we can't stop eating. We have to eat. And that's the biggest difference between addiction and eating disorders is we can't abstain. Abstaining means thinking about it differently and addressing the cognitive distortions and dealing with our emotions and talking about it, which is harder than abstaining. Because you can white knuckle through a lot of things if you have to, especially in the early days of the recovery process, but you can't do that forever. And you have to, at some point, go live your life.
Do you get a lot of clients that, you're able to encourage to kind of work towards their goal, or are they stuck because they're fearing all those things?
Honestly, for the last 15 years, by the time a client gets to me, they've had a couple of other therapists. They've been to a generalist. They've been to someone who doesn't know eating disorders very well, or who has addressed some other aspect of their issues like anxiety or depression or trauma and not addressed the eating disorder, a lot of times the therapist hasn't even asked about their eating behavior or how they feel about their body. So some of it is being fed up with no one understanding where they're coming from or being able to talk about it, and they just want to talk about it. So most of the time, people have a goal in mind. When they're stuck in wanting to stay thin but have a life at the same time, like that's the most common paradigm when you're working with someone who's inpatient or residential level of care. They're afraid to gain weight. They're afraid to go back to their life. What are they afraid of is the question, not what are your goals, because you can't even get to the goals if you're still engaging in the self-destructive behavior. They don't even know what they want from their life when they're in that part of the recovery process. You have to get away from the behaviors before you can even think clearly. And that's the scariest part. These people are usually really amazing, smart, wonderful people who are successful in a lot of areas in their life. And it doesn't look like from the outside anything is wrong. People reinforce it all the time, especially if they think that it helps the person succeed, like perfectionism. That works great in school and work most of the time. It's in the relational aspects of our life that perfectionism really fails. And the same is true with the eating disorder. It's not black and white, it's all shades of gray.
You've touched on so many different aspects of this. Is there anything else you want to share with our listeners that is really important that you want to get out there?
One of the things that I think is really important when it comes to talking about eating disorders differently is examining your own feelings about your body. Like if any therapist is going to work with its population, they need to sincerely sit down and think about how they view their body, what their preferences and goals are. I would tell people to go take the implicit attitudes test. If you guys have ever heard of that, there's a bunch of different kinds of tests. They're about gender and race and weight and politics and a ton of other things. But if you look up Harvard IAT, it'll give you the whole list. But the weights one is especially important when we're talking about the eating disorder portion of the conversation, because almost everyone has a preference, a bias. Just knowing what it is can help you deal with other people's and maybe help you manage that when you're dealing with someone who has an eating disorder. But interestingly enough, and this is true of most biases, people who once considered themselves fat and have lost the weight and now consider themselves thin have the most negative bias towards other fat people. And we look at it like it's a moral failing or like someone really has that much control over their weight. We don't have that much control. Genetics account for almost half of it by most estimations. And obviously there's some disagreement there, but genetics and environment is almost all of it. And the behaviors that we do on a day-to-day basis account for probably 20% of our control over our weight. 20% can be a lot. 20% can get you in a whole lot of trouble in terms of your health. So it's probably good that we don't have more, because more people would be dying.
You've definitely touched on a lot of important topics, and we're going to put all the links up that you share with us so that everyone can get that information. And I'm so happy that you're on here. You have a lot of passion for it, and you have a lot of good information that you've shared with us. So I thank you very much.
Yes, thank you.
Happy to be here.
And thank you to our listeners, and we'll see you next time.
Thank you so much for joining us here today on the Counseling Podcast with Dr. Jacqueline and Dr. Stokes. Please take this time to thank yourself for putting in the work. If this episode impacted you in any way, let us know with a loving and honest review. If you have any questions or want to continue the conversation from today, you can reach out to us at thecounselingpodcast@gmail.com, and we can answer your questions right here on the show. Or you can find Dr. Jacqueline and Dr. Stokes on Instagram at DocJacqueline and at dr.jeremiah.stokes.